Hello everyone. My name is Vikram Rangan. I'm one of the gastroenterologists at Beth Israel Hospital, and I will be speaking to you today on modern strategies to treat irritable bowel syndrome. I have no disclosures. And so I know we just spoke about a lot about irritable bowel syndrome, so I won't spend a ton of time on the IBS definition, but I just wanted to briefly mention the IBS definition and characterization just so that we can keep it in mind because treatments vary quite a bit based on the specific subtype of IBS that we're dealing with. So once again, IBS is recurrent abdominal pain at least 1 day per week in the last 3 months, associated with defecation, change in bowel frequency, or change in stool form. And again, criteria must be fulfilled for the last 3 months with symptom onset at least 6 months prior. And then once a diagnosis of irritable bowel syndrome is made, IBS is subtyped based on the percentage of hard or lumpy stools and based on the percentage of loose or watery stools. And so patients are characterized as having IBS-C, IBS-D, IBS-M if they have over 25% hard or lumpy stools and over 25% loose or watery stools. And then IBS-U if they have abnormal bowel function and abdominal pain, but do not quite meet the criteria for IBS-C or IBS-D. There are multiple pathophysiological mechanisms involved in irritable bowel syndrome. And again, these have been discussed already, so not going to go into a whole lot of detail, but just mentioning these multiple mechanisms because they inform the various treatments that are available, since many of these treatments specifically target one of these links in the IBS mechanism. So, abnormal brain-gut connection, gut dysbiosis, possible bile acid malabsorption, possible food sensitivity. All of these play a role in IBS pathogenesis. So with that background, I'll jump into specific treatments for irritable bowel syndrome, and we'll kind of divide this into general measures to be considered for all patients with irritable bowel syndrome. We'll talk a little bit more about measures that are more specifically targeted towards either constipation or diarrhea. And then lastly, we'll talk about measures that are more specifically targeted towards pain symptoms. So in terms of general measures for IBS, I'll generally be following the guidelines from the American Gastroenterological Association. There was also a recent guideline from the American College of Gastroenterology, or ACG, and so I'll mention those as well. But these AGA guidelines are the main ones that I'll be following here. And so before we even distinguish patients based on IBS subtype, there are a couple of measures that carry a recommendation for basically everyone with irritable bowel syndrome. So these include a strong provider-patient relationship, education and reassurance on the benign nature of irritable bowel syndrome, lifestyle modifications like improved exercise, improved sleep and stress reduction, and dietary modifications, which we'll talk a little bit more about. So first things first, just mentioning the strong provider-patient relationship. It seemingly goes without saying that having a strong relationship between the provider and patient is a beneficial thing, but it's worth noting that this actually has been proven out in actual studies. And so this one study compared augmented patient-provider relationship with a more limited patient-provider relationship and showed significant improvement and global improvement and various other endpoints in those with this augmented practitioner-patient relationship. These are all aspects of the augmented practitioner-patient relationship. So warm, empathetic, active listening, thoughtful silence, physical contact. These are all aspects of the provider-patient relationship that are beneficial. So again, this is something that actually has research behind it. It's been shown that physical activity improves symptoms with IBS as well. This one study from 2011 shows that 12 weeks of moderate to vigorous activity was associated with improvement in the IBS SSS, which is a scoring scale that's used to measure IBS severity. It's commonly recognized that food plays a significant role in IBS symptoms. Among those with IBS, there's approximately a 2 times greater prevalence of perceived food intolerance, and as many as 2/3 of IBS patients report having symptoms with eating a meal. And there are many possible mechanisms for this, including food intolerance, strong gastrocolic reflex, um, whether there's some sort of fermentation by certain food contents based on a specific individual's microbiome fingerprint. Um, so it's well established that food plays a role in IBS pathogenesis. However, recognition of specific food triggers is quite difficult. Um, there are a lot of patients who do try and pursue allergy testing to identify specific food triggers, but this is something that's actually not recommended by the gastroenterological societies, in large part because IBS in many cases is driven by food intolerances that don't lead to actual IgE-mediated allergies. And a lot of times these allergy tests not only don't correlate all that well with the specific IBS triggers, but may also lead to patients unnecessarily restricting their diets as well. Um, in large part because many IBS patients note that prolonged fasting shows marked improvement of IBS symptoms. So it's important for all IBS patients to be aware of the role that food plays, to ask about food triggers and just to be cognizant of the role that diet plays and to have a low threshold for involving a dietitian or a nutritionist in the patient's care. But I would also say that we should be cautious about recommending food elimination or other restrictions, just because identification of specific triggers is such a challenge. So the one diet that does carry evidence for efficacy in irritable bowel syndrome is this low FODMAP diet. FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Um, Basically, all of these are carbohydrates that are prone to be fermented by the gut and will often lead to increased gas production and can also be associated with diarrhea due to these end products of fermentation in the gut. So it has been proven that eliminating these high FODMAP foods does lead to improvement in global IBS symptoms. The main challenge is that the low FODMAP diet is very restrictive. As you can see, there are a wide variety of foods that fall under this FODMAP umbrella. And many of these foods are ones that we typically think of as being quite healthy, things like broccoli, asparagus, many fruits, etc. Um, and so, there is evidence, like we talked about the low FODMAP diet being efficacious. This is a study that compared the low FODMAP diet to the modified Nice diet, which basically is oftentimes thought of as kind of a common sense diet for irritable bowel syndrome. And this study did show that for various endpoints, the low FODMAP diet was more effective than this modified Nice diet. Um, but with that said, the low FODMAP diet is very restrictive, and it's generally not possible to maintain this complete low FODMAP diet over the long period of time, just given the number of foods that are on it. And so, in general, it's recommended that all of these food groups are initially eliminated for a period of 4 to 6 weeks, and then, if effective, certain food groups should be reintroduced to help the patient arrive at a more personalized diet, and involvement of a dietitian is usually very important in this. Um, Given how challenging it is to complete this low FODMAP elimination, there's also been increased talk recently about rather than doing this step down approach where we eliminate everything at first and then slowly reintroduce foods, perhaps more of a step up approach where we start by eliminating more common triggers. The fructans in particular have been pointed to as particularly strong culprits within the FODMAP umbrella and kind of adding additional eliminations as needed. So So those are a couple of directions that the low FODMAP diet may take going forward, given its difficulty in adhering to it. So the American College of Gastroenterology recommends a limited trial of the low FODMAP diet to improve global IBS symptoms. But again, only the initial elimination phase has been evaluated thus far. This reintroduction phase still needs to be studied further. And other approaches, such as the step up and step down approach to the low FODMAP diet, also need to be studied. Additionally, um, given how restrictive it is, patients in whom we're pursuing the low FODMAP diet should be assessed for possible eating disorders, since recommending a very restrictive diet like this could negatively impact those patients with an existing eating disorder or in whom there's concern over existing nutritional status. Finally, fiber supplementation has been shown to be effective in IBS. The ACG guidelines suggest soluble but not insoluble fiber, in large part because insoluble fiber tends to be a little bit more gas producing and can also lead to an increase in bowel frequency that's not desirable for all patients with irritable bowel syndrome. So the soluble fiber is thought to be helpful both for IBS with constipation and diarrhea, mainly because of its bulk forming effect on stool, and there are a couple of other beneficial nutritional effects as well. So these are a couple of measures that typically we think of for all IBS patients, the strong patient-provider relationship, lifestyle modifications like exercise, and then fiber and dietary approaches like the low FODMAP diet should be considered for all IBS patients, but the latter two, especially the low FODMAP diet, are not necessarily for everyone. Moving on to treatments for constipation. So for those who specifically fall under the IBS-C umbrella, or for those under the IBS mixed umbrella who are significantly bothered by constipation symptoms. So for those with constipation, a common sense starting point is osmotic laxatives like Miralax or polyethylene glycol, or other options like magnesium oxide, milk of magnesium, magnesium citrate, etc. It should be noted that these old school osmotic laxatives have been around for so long that they haven't been all that well studied using our modern IBS endpoints. And as a result, support for these osmotic laxatives based on these guideline recommendations is actually somewhat tepid. Um, but there is evidence that polyethylene glycol or Miralax improves the frequency of complete spontaneous bowel movements. There's not evidence of Miralax clearly improving abdominal pain or abdominal discomfort. And so as a result, there actually was some discrepancy between the recommendations from the ACG and the AGA. The ACG technically does not recommend Miralax for global IBS symptoms, whereas the AGA guidelines do recommend Miralax as a first-line treatment for IBS with constipation. And even though the evidence is not all that great, given how long this medication has been around, you know, in mine and other common GI practices, it's very common to utilize Miralax or other osmotic laxatives as a first-line common sense treatment. So, so polyethylene glycol, again, magnesium citrate, milk of magnesia, are other very commonly utilized osmotic laxatives that are utilized as a first line. It's worth noting as well that a lot of times these osmotic laxatives work very well when combined with a stimulant laxative like Dulcolax or Senokot, since the mechanisms of action between an osmotic laxative and a stimulant laxatives are often quite synergistic. The stimulant laxatives also do not appear in the GI guidelines from either the AGA or the ACG, largely for the same reason. These medications have just been around for so long that there aren't a whole lot of modern trials using modern endpoints for them. But again, from a practical perspective, I think both these osmotic laxatives and stimulant laxatives, often used in combination, represent a very logical starting point. a lot of times we'll recommend something like an osmotic laxative on a daily basis and a stimulant laxative once every 2 to 3 days, especially if the patient has not had a significant interval bowel movement. Um, so once we move past the initial first-line treatments of osmotic and stimulant laxative, there are multiple other prescription laxatives that have come into practice within the last decade or so. And there are multiple mechanisms of action. But for all of these, the end effect is fairly similar, which is increasing secretion of water into the gut lumen. So, the specific channels that these medications act on is a little different. So, for example, lubiprostone acts on the CCL2 channel to increase chloride secretion in the gut. Tenapanor acts on the sodium and hydrogen channel. But at the end of the day, all of these secretagogue laxatives have the same end effect. Um, so I'm not going to go into a whole lot of detail on the specific clinical trials. You'll see the percentage of responders is a little bit different in all these trials, in large part because the endpoints are not exactly the same across trials. But bottom line is that there is evidence for effectiveness of lubiprostone or Amitiza for IBS with constipation. Lubiprostone also is indicated for opioid-induced constipation as well. And there's evidence for improvement in various endpoints, including discomfort, pain, bloating, bowel frequency, and whatnot. Amitiza or lubiprostone, the main reported side effects are both nausea and diarrhea symptoms. So linaclotide or Linzess also has evidence of efficacy in improving not only bowel frequency, but also these additional symptoms like abdominal pain for those with IBS with constipation. Its most common adverse effect is diarrhea. Um, um, Linaclotide tends to be more associated with diarrhea than some of the other secretagogue laxatives. It does come in 3 different doses, which is one advantage and gives a little bit of latitude for dose adjustment. But again, its overall profile is similar to that of the other secretagogues in that it's effective for both bowel frequency and has demonstrated effectiveness for other IBS symptoms and carries the side effect of diarrhea primarily. Plecanatide or Trulance is another secretagogue laxative that acts by the same mechanism of action as linaclotide or Linzess. Once again, there is evidence for effectiveness in both bowel frequency as well as this composite endpoint. And once again, its main side effect is diarrhea. Plecanatide is thought to have less in the way of diarrhea side effects than Linzess or linaclotide, but it is nonetheless a side effect that we do need to keep in mind with it. And then Motegrity or prucalopride, this is a newer prescription laxative medication. This has a slightly different mechanism of action than the secretagogue laxatives that we spoke about before with plecanatide, linaclotide, and lubiprostone. Prucalopride or Motegrity is a 5-HT4 agonist that basically promotes motility of the gut rather than secretion of fluid into the gut lumen. So a main advantage of Motegrity is it's thought to have a pan-GI tract pro-motility effect. And so it's oftentimes utilized in patients who have dysmotility of other parts of the gut as well. So for patients with documented gastroparesis as well as constipation, Motegrity can be a very valuable treatment adjunct there. This trial compared a dose of 2 milligrams and 4 milligrams with placebo. In our current clinical practice, 2 milligrams is considered the maximum dose of Motegrity, which is utilized once a day. So again, there are multiple trials that have demonstrated improved complete spontaneous bowel movement frequency. It has a slightly bigger side effect profile. In addition to diarrhea, it's been associated with headache, nausea, and abdominal pain as well, given that it is a stimulant medication. Um, And then tenapanor is another newer, more recently approved medication for IBS with constipation. And again, it acts on sodium hydrogen channels in the gut lumen. And once again, it also has been associated with improvements in bowel frequency and composite endpoints in irritable bowel syndrome. And like we talked about with linaclotide and lubiprostone, its main adverse effect is diarrhea. So that's kind of a brief rundown of the various prescription treatments for IBS with constipation. So again, typically we'll start with one of the osmotic laxatives, oftentimes in combination with one of the stimulant laxatives as a common sense starting point. And then if there's a lack of effectiveness there, we will oftentimes move on to one of these prescription laxatives going forward. In terms of the specific prescription laxative that's utilized, there's not a clear-cut algorithm for which medication comes first, and a lot of times, to be completely honest, the patient's insurance will largely dictate things. Um, but with that said, I would say that in patients with concomitant gastroparesis, motegrity might be a valuable first-line option. Um, if there's significant concern for diarrhea as a side effect, plecanatide may be a slightly better option than linaclotide or lubiprostone. Um, but again, among these prescription laxatives, there's not really a clear-cut progression from one medication to another. A lot of times we will start with the linaclotide or lubiprostone since we tend to have a little bit more experience with those. But again, that's not something that's set in stone. So this is a meta-analysis basically showing that all of these treatments for IBS-C have demonstrated efficacy compared to placebo. And again, Linzess, perhaps there's a little bit more efficacy with that, but there's not really a clear-cut hierarchy or order between these various treatments. And the study concluded that efficacy was similar among individual drugs and doses for most endpoints to that point. So moving on to irritable bowel syndrome with diarrhea, as is the case with the irritable bowel syndrome with constipation, a lot of patients are treated with either with one of these antidiarrheals like Imodium, Lomotil, or bile acid sequestrants as first line. And once again, the evidence for these medications is not great, in large part because these medications have been around for quite some time and haven't been the subject of modern clinical trials with modern endpoints. And so loperamide is the only antidiarrheal that's been studied, and there have been 3 randomized control trials that have not been of great quality. And so there is evidence that there's an improvement in stool frequency with loperamide, just like how there was this improvement in stool frequency with the polyethylene glycol as well. But there was not this demonstrated improvement in abdominal pain or global IBS symptoms, the same way as was with the case with Miralax. And so again, even though the evidence is not great, loperamide is suggested for IBS-D by the AGA guidelines, in large part because it is a common sense initial treatment, it's easily available, and its side effect profile is fairly benign as well. The main side effect with loperamide is, worsening constipation and potentially causing some increased abdominal discomfort as a result of that. So bile acid sequestrants are another class of medication that has been utilized for IBS for quite some time. Once again, they haven't been the subject of a whole lot of modern research trials, in large part because they are being used off-label for IBS. This is a study of colicevalam in those with proven bile acid diarrhea. And as you can see, there is this fairly dramatic improvement in remission in those who are on the bile acid sequestrant. In our current clinical practice, testing for bile acid diarrhea is not all that common. Like there is this serum marker, the 7-alpha C4 test, but it's not utilized all that commonly in our current clinical practice, although hopefully utilization will increase going forward. And so in large part, in patients in whom we're suspecting bile acid diarrhea, especially those with a history of cholecystectomy, we'll oftentimes empirically give a trial of one of these bile acid sequestrants, whether it be cholesevelam, cholestid, cholestyramine, and whatnot. And a lot of times, even in those with irritable bowel syndrome with diarrhea without a documented history of cholecystectomy, it still is oftentimes worthwhile to do a trial of a bile acid sequestrant, which is oftentimes very effective for reducing bowel frequency, even though there hasn't been this proven improvement in global IBS symptoms in IBSD. Um, there's only been this study in those with the proven bile salt diarrhea, and even among those patients, there are these known adverse events like bloating and abdominal pain. Um, so again, ACG guidelines do not suggest bile acid sequestrant for global IBS symptoms, but just as is the case for Miralax and loperamide, it is a common sense treatment that oftentimes is utilized as a first line or as an early stage treatment in those who are particularly bothered by increased bowel frequency. So once again, moving to the newer medications that have been studied a little bit more extensively recently. Rifaximin is a gut-specific antibiotic that has activity on the gut microbiota. Although again, the specific gut bacteria strains that it acts on are still not all that well known. Um, and so these target trials have proven that the 2-week course of rifaximin is associated with relief in global IBS-D symptoms and in bloating symptoms as well, and also demonstrated that retreatment in patients who have already undergone one course of treatment can be effective as well. A lot of patients like rifaximin, given that it is just a 2-week treatment course rather than an indefinite treatment. Um, in our current clinical practice, the cost of treatment oftentimes is the main impediment to prescribing it. But especially in those with a combination of diarrhea and bloating, rifaximin is a commonly utilized and helpful option. Um, Aloxadeline or Vyburzi is a newer treatment that acts as a mixed mu opioid agonist and delta receptor antagonist. It has been demonstrated to improve global symptoms in IBS-D. The main adverse event associated with aloxadeline is sphincter of Oddi dysfunction and pancreatitis. The concern for this is primarily in patients with a history of cholecystectomy or in patients with ongoing alcohol use. And so therefore, this medication is actually relatively contraindicated in those with cholecystectomy or with ongoing alcohol use. But in those without in those with gallbladder in situ, it is a useful treatment option in those who haven't responded to either traditional antidiarrheals or bile acid sequestrant medications. Um, and then allosetron is a serotonin receptor antagonist that has been shown to improve global symptoms in women with severe IBS-D. Allosetron is likely effective in male patients as well, although it hasn't specifically been studied in that population. Olocitron does come with this black box warning for ischemic colitis, and this adverse effect is constipation dose dependent and much more likely to occur in those who are treated to the point of constipation. And so Olocitron is not used as a first-line treatment, but can be a valuable second-line treatment in female patients who have not responded to prior treatments. And it's just important that those female patients who are treated with Olocitron are closely monitored to ensure that they're not treated to the point of constipation for the sake of reducing the likelihood of this adverse event. So once again, there's this meta-analysis that demonstrates the effectiveness of these various treatments for IBS-D, and there's the suggestion that Olocitron is the more effective one compared to Vyburzi and rifaximin. although once again, coming with this black box warning, given the risk of ischemic colitis with it. So moving on, as we talked about at the beginning, pain is a cardinal symptom of IBS. And even though improving underlying bowel function oftentimes is associated with improvement in pain symptoms, it's common for pain to persist despite improvement in underlying bowel function. And so keeping an eye on pain symptoms and treating those is another very important aspect of IBS management. So again, the AGA per the AGA guidelines, will usually try and treat underlying bowel function, and if abdominal pain is persistent afterwards, we'll more specifically target treatments towards it. So unfortunately, our armamentarium for treating GI-related pain is not all that vast. So the majority of treatments are these gut antispasmodic treatments. So dicyclomine and hyoscyamine are both anticholinergics that reduce bowel contraction and spasm type abdominal pain. Peppermint oil is thought to act on calcium channels and have this similar gut antispasm effect. And so there's not a lot of great evidence for these medications, but there does exist literature showing that these medications improve abdominal pain, and there is some evidence for global IBS symptom improvement with these antispasmodics as well. And so this is a study looking at peppermint oil specifically. And basically, the systemic review does indicate that peppermint oil medications overall seem to improve global IBS symptoms, though there are often these adverse effects like GERD, dyspepsia, and flatulence. You know, being a smooth muscle relaxant, peppermint oil medications are thought to relax the lower esophageal sphincter and predispose to GERD symptoms as well. Tricyclic antidepressants are kind of our centerpiece in treating abdominal pain related to irritable bowel syndrome. There are 4 randomized controlled trials that have shown a significant reduction in pain with these tricyclic antidepressants. Unfortunately, these medications are associated with significant adverse effects like fatigue, dry mouth, and whatnot. And in addition, for a lot of patients, the perception of these medications as being antidepressants is another impediment. And so patient education on the specific role and their utilization as nerve modulators rather than antidepressants is very important. And with these, there are various tricyclic antidepressants available. Nortriptyline and desipramine tend to be less associated with sedating and gut-slowing side effects than amitriptyline and imipramine. The latter 2 medications are oftentimes utilized specifically in patients with irritable bowel syndrome with diarrhea, although recent studies have pointed to TCAs as a class being efficacious for IBS in general, and our guidelines do recommend them for pain in IBS and not specifically for those with IBS-D only. And then there's this newer awareness of psychological treatments for not only IBS, but also specifically for pain related to IBS. And there are these various techniques, such as gut-directed hypnotherapy, cognitive behavioral therapy, multi-component psychological therapy, that have been shown to improve global IBS symptoms as well as IBS-related pain. And more recently, there are these various apps like the Nerva app that have been demonstrated to be efficacious as well. And so perhaps it may not even be necessary to have a patient link up with a GI psychologist, since there oftentimes is limited availability of people with that type of expertise. And so these newer treatments, like these newer psychologic treatments like CBT and gut-directed hypnotherapy, have a comparatively lower number needed to treat compared to these more typical IBS treatments like rifaximin and linaclotide. The TCAs are also demonstrated to have a relatively low number needed to treat as well. I hope I've shown you that there are a multitude of IBS treatments that are available, and Identifying the specific treatment for the specific patient basically entails thinking through what the primary symptom driver is for the individual patient. Sometimes testing can help us, like anorectal manometry to assess an evacuation disorder or a SITS marker study to assess for abnormal transit. And so I would emphasize the importance of tailoring treatment to what we believe the main symptom driver is. And a lot of times, clinical judgment is the main tool that we have to identify the specific symptom driver. I'm going to quickly mention that there are some treatments that still require further evidence for IBS. Probiotics are very commonly utilized. Thus far, the evidence for them is somewhat limited, and current ACG guidelines suggest against their use for global IBS symptoms. But there was a meta-analysis that did suggest overall global improvement, and newer studies have also pointed to its efficacy. So this is something that likely will play more of a role in IBS management moving forward. Similarly, there's been a lot of interest in fecal microbiota transplant and prebiotics. Thus far, there's insufficient evidence to support their use for IBS, but these are additional treatments to keep in mind moving forward as additional studies are completed. I'll conclude by saying that obvious interventions like the strong patient-physician relationship and lifestyle modifications like exercise should not be underplayed as they play a very important role in IBS management. We should ensure that treatments are targeted to the predominant symptom or the predominant underlying cause for symptoms if one has been identified based on testing. We should keep a close eye on the dietary component to symptoms and not push overly restrictive diets on those with eating disorders. And we should always be cognizant of psychological comorbidities. And in addition, make sure that pain symptoms are specifically targeted when necessary for IBS management.